Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
What's up, y'all?
I'm Justin Burt, joined tonight by Dr. Chris the Chew Man Chew and our wonderful producer, Dr. Rachel Holloway. How's it going, Rachel?
It's going great, thanks.
You put together a wonderful episode with a wonderful guest tonight, Dr. Nancy Crimmins, here to discuss pediatric type 2 diabetes. Wonderful topic. But before we dive into the show, Chris, can you remind us about who we are and what we do?
Sure. We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
Tonight we have a fantastic conversation with our guest, Dr. Nancy Crimmins. Dr. Crimmins is a pediatric endocrinologist at Cincinnati Children's Hospital Medical Center with interest in obesity and diabetes. She is program director for one of the largest peds endocrine fellowships in the country and enjoys teaching, mentoring, and really likes it when trainees aren't afraid to ask questions. Fun fact, Dr. Crimmins does not enjoy listening to podcasts at all, unlike all of her close friends, but loves live conversations, so is always happy to participate in them. In this episode, Dr. Crimmins teaches us how to diagnose, treat, and screen for complications of pediatric type 2 diabetes.
All right, guys, grab a snack. Get ready for some sweet pearls.
Dr. Crimmins, welcome to the Cribsiders. Thanks so much for coming on to the show.
Happy to be here.
As we do with all our guests, we're a very informal group, as we mentioned. We're like the cool mom. We kind of let things go. Is it cool if we go by your first name? We do first name guests. Is that cool, Nancy?
Absolutely. No problem.
Excellent. All right. We're already becoming friends. Would love to get to know you better, though. Our audience would love to get to know you a bit better. And so can you give us a little bit of a one-liner, maybe an introduction to yourself and maybe something you're interested in outside the field of medicine?
Yeah, sure. So, again, Nancy Crimmins. I'm an endocrinologist at Cincinnati Children's. I'm a mom of both children and puppies, and I love to read, and I love to travel and wander around.
Can I ask a good book? Not to steal someone else's question, but if you're a big reader, any book recommendations that you've had in the past year or so that are...
Yeah, so I read voraciously. My mom was a librarian, so that's like sort of my escape type thing from medicine and the other things that I do. I just finished a trilogy called the Winnowing Fire trilogy, and it's really cool. It's by Jen Williams, and it's like a combination of sci-fi, fantasy, and horror all in one trilogy, and I enjoyed it. So, yeah.
I never gotten the sci-fi genre as much. I should. People love it when they...
I've been asked to read this Murderbot series like over and over again.
I have friends who love that. Absolutely love that series. I have not read that.
Yeah, I've heard great things.
It's just a cool name. I guess I can ask the next question. You said you're a voracious traveler as well?
Yeah, I really like to. I have a couple besties. We go on a travel trip once a year. Usually involves hiking in nature to some degree. So our last one was South Africa, but we've done like the country of Georgia. Sometimes we had national park.
What's on your bucket list that you haven't gone to yet?
Okay, so I turned 50 in August, and I wanted to go to Finland because the last 8 years it's been voted happiest country in the world. And I feel like that's a good place to spend your 50th birthday. I'm hitting Finland in August.
50s in Finland.
Yeah, and it's an alliteration, which works well.
Amazing.
So,
I think the Finnish really love their saunas, right? That's one of their things.
They do.
So you probably should try.
I think a lot of the saunas in the United States, I think, were from and manufactured in Finland.
Is that right?
So, I actually hate saunas. Like, I don't know why anyone would want to get hot and sweaty on purpose, but
there's other stuff there. I'm sure. I'm sure there's other stuff.
I take it as just they're chill people.
Yeah, they like to relax. Yeah, take it easy.
Yeah,
that's awesome.
Sure.
I have another question, maybe getting a little bit more serious, but as a trainee, as a resident, I like to ask this question because it kind of helps me as I develop into a clinician. What is a piece of advice that you have ever received as a learner, a teacher, or at any point in your career that's really stuck with you and resonated with you?
Let's see. I would say probably the thing I look to the most consistently, let's say, through training is my mentor, who is now my division director and who's an awesome guy. I was upset about something that I had seen that another provider was doing, and he was like, you can't take responsibility for other people's actions, right? Like, you own your patients, you do the best that you can every single day, and you need to evaluate yourself and how you feel like you're doing. And of course, that's my job too. And that's really helped a lot. I think there's a lot of burnout in medicine, and it's just kind of helped me stay on track and stay in my lane. And then I think at the same time, still pushing me to always do the best I can do and by my patients and my trainees. I'm also a program director for endocrinology and one of the biggest fellowships in the country. And so I try to tell my trainees that too, because otherwise I think you just sort of sink into, complaints and the quagmire of things that are dark.
It's great life advice. I feel like it's like one of those control what you can, not what you can't. Yeah.
And then I think for the trainees, it's like I'm always just pushing them to ask questions. I think a lot of times they just want to look it up and just get these concrete answers and just like really step back and look at the big picture. Like, what do you need to know to really treat this patient the best? And especially with like Epic and algorithms, I think sometimes people don't know. And so they just pull up the algorithm or the template, in Epic and start asking the questions down there and don't really step back, and each patient's a little different.
That's great advice.
One thing we're going to do for this episode that we haven't done in a while, and Nancy, you're welcome to participate if you'd like, but we're going to do a quick round of pick of the week.
It's coming back.
Where we each kind of share something that's either media or an object or just something in life that we have enjoyed the pick of the week. Chris, do you want to start us off? What's your pick of the week?
So, I was on YouTube recently because a lot of people are on YouTube, and I follow this channel. I think it's called The Gaming Historian, and he recently did a documentary on the video game Oregon Trail, which I think is a seminal part of my life because some people have called me a geriatric millennial. I've often considered myself Gen X, actually, because I'm sort of like the end of Gen X. But I think more recently, I've considered myself the Oregon Trail generation, which is like this micro generation between Gen X and millennial. So watching this more than hour-long documentary on the development of Oregon Trail really like hit all the nostalgia points, and I loved it. So if you guys are around my age, maybe you'll enjoy it too. But actually, I
totally played Oregon Trail. Are you kidding? I love that game. Yeah, I feel like Rachel and Justin may be too young for Oregon Trail, but like it was so fantastic. Like you always died of things like dysentery. The ox ran over you and your family or something. So.
I feel like I was the Oregon Trail 2 generation. Like I remember growing up on Oregon Trail 2. Rachel, how about you? Do you have a pick of the week?
I actually do. And Nancy, I think you'll like this one. So anyone who knows me in real life knows that I can't stop just raving about this podcast that I love. It's called National Park After Dark, and essentially it's these two friends who will tell stories about history, survival stories, kind of dark and twisted things that happen in national parks. And as part of their episode, they will tell you a little bit about the park, what the beautiful trails and views are, the number of visitors, how to be safe in that park, bears and all of these predators and how to protect yourself. And so they give advice on how to recreate responsibly, but they also, in the same episode, will tell you an interesting historical story or, some sort of survival story and that happened in that park. So I find it really fun because I really enjoy national parks as well. And so if I'm going to go to a certain park, then I can listen to the episode and say, okay, this is cool. I have a little bit of context as far as, what I'm looking at.
Love that.
So do they say things like, this is the best spot if you want to spot Bigfoot or
yeah, exactly. They'll talk about like cryptids and they'll be like, I don't know if moose are real or, that's like their whole thing. They're like, we believe in Bigfoot, but I don't know if moose are real. so yeah, it's awesome. Really interesting. And then they'll have callers call in. They do these things called trail tales where listeners will tell their own stories. And there have been so many times where people are like, yeah, we were out there in the woods faking Bigfoot for these people. Then we got caught in this scenario, and it's really fun to listen to.
Oh, it's hilarious. I'll do mine quickly. It's related to podcast. I just checked out Chris Demas. He used to be a med student at Brown. Now he's a resident. And he created a podcast called First Pediatrics. First Pediatrics, not Second Pediatrics. That podcast sucks. But First Pediatrics. And it basically is basic complaints on inpatient wards from a resident perspective. And one of their first episodes was bronchiolitis. And so it's kind of a cool, like early trainee, bite-sized tips for pediatric medicine. And, we're all about kind of sharing the wealth, and it's a cool kind of different podcast than us. And so worth checking out for other people that have interest.
It's also on Chris Demas's YouTube, actually under Christopher Demas. I think they have like 5 episodes out. I just listened to their hyperbilirubinemia episode. It was really good.
Dope.
I think people should check it out.
Lightning round, Nancy. Anything else that we should check out?
Okay, so I don't listen to podcasts, even though I'm doing this one, so I can't really help you there.
Yeah, who likes podcasts?
The only thing new I learned this week is I didn't know what LARPing was. Oh. Am I like totally behind? So I was in HealthWorks clinic, which is our weight management clinic, and one of the patients was getting into that. And I'm like, what on earth? But Cincinnati is a big league, like a big one, and that they get. Well, anyway, didn't know what that was.
There are some LARPing tales that go dark.
I don't know what LARPing is.
Yes, Rachel.
Live action role play.
You guys aren't nerds like me and Chris. It's not a generational thing.
I think they get like costumes and like foam swords and battle it out. And I don't know how they decide characters or who wins or how long it goes, but
the characters pick you.
I see.
So there's a hilarious movie that stars Peter Dinklage about LARPing. I think like Danny Pudi and a couple other like really great people are in it, called Knights of Badassdom. It's about LARPing. People should check it out.
We'll check it out, yeah. Huh.
LARPing's a great pick of the week.
Hey, Cribsiders listeners. We've been talking about Freed for the last few weeks, and I thought I should give you a bit more of a background. So Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. We've kind of told you that part already. But what's new is the background. So Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it would mean that he could spend more time with Gabby, who is spending nights, weekends, and holidays updating medical documentation. Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All of the magic happens in just a few clicks. So clinicians can spend less energy on charting and more time on what they do best. Most importantly, Freed is HIPAA compliant. It learns your style over time, just like any human scribe. At $99 per month, more than 4,000 clinicians and their spouses have fallen in love with Freed. But good news, Cribsiders listeners, you can try Freed for free right now by going to freed.ai. And listeners of the Cribsiders podcast can use code CRIB50 for $50 off their first month. That's code CRIB50 for $50 off that first month.
We got to dive into some content.
Oh, yeah.
This is great. This is
That's
fun.
why we're here.
Let's talk about kiddos who have sugar in their blood. Rachel, you want to get started with our first case?
Absolutely. Okay, so this is a case from Cashlack Children's. Diane Sweetie is a 14-year-old girl who presents to clinic for her well child check with her mother. On reviewing her vitals, you notice that her weight is 98th percentile for her age. When asked about nutrition, she reports feeling like she refills her water bottle and goes to the bathroom a little bit more often than her peers. She also has to get up 2 to 3 times to use the restroom at night. On exam, she's noted to have a large body habitus for her age and darkening and thickening of the skin to her axillae and her posterior neck. You get screening labs, and she is noted to have an A1C of 6.7. So this episode, not to spoil it, is about diabetes, and we'd like to start off from the basics, Dr. Crimmins, about a brief background of the pathophysiology and the disease in question. So I'm wondering if you could just briefly review the pathophysiology of type 2 diabetes and how it differs from type 1, because I feel we see type 1 diabetes much more often in pediatrics.
Right, right. So, just to review, type 1's an autoimmune disease with beta cell destruction, and type 2 is different because it really has insulin resistance, not insulin deficiency at the core. So that the clue in the case is that darkening of the skin, which is called acanthosis nigricans, but it's this outward manifestation of insulin resistance that gives you that hint. That said, insulin resistance is pretty common in children with obesity, and type 2 diabetes is still not that common. It's becoming more common. But so there seems to be some genetic predisposition to have beta cell dysfunction that the cells just can't accommodate for the insulin resistance. And over time is when you see those blood sugars start to come up. And we still have a lot to learn to understand which kids are at the most risk for that. But we're definitely seeing it more, especially in minority populations, people of color.
And you mentioned the acanthosis nigricans is one of the presenting symptoms, and obesity is also kind of a proxy for insulin resistance, or that it's a common comorbidity. Are there other presenting symptoms or things that make you start thinking about someone with type 2 diabetes mellitus?
Yeah. That case that you presented, and I don't know who wrote it or where it came from. I'm sure it's legit, but a lot of times they don't have symptoms, and especially not an A1C of 6.7. Like 6.7 is technically goal. It's under, we like to get them under 6.5, but under 7, we feel pretty good. That's an average of I don't know, maybe 140 or something. So I'd be really surprised to see symptoms at that. And the other reason I bring it up is a lot of the kids don't have symptoms at all. And so that's why the screening is so important. You can see DK in type 2 diabetes. You can see symptoms like that, but it's just not as classic as the type 1 kids in many of the cases.
And maybe building on that, it sounds like a lot of the presentations of new type 2 diabetes come from screening, kind of asymptomatic screening before they start having this nocturia or polyuria or acanthosis nigricans.
Yeah, I feel like it's either picked up on screening or because of atypical weight loss, which you can see in type 2. So a lot of times it's actually really sad. Sometimes the kids have really been trying to lose weight and they lose a significant amount of weight and they're happy about it. And then you do the screening labs and it's because they have diabetes. It's uncontrolled, So I think you really can see a pretty wide spectrum from really no symptoms at all the way up to more typical symptoms you see with type 1 diabetes, like polyuria, polydipsia, acidosis, that kind of thing. I think the other hint is if you have another condition that fits with more of a type 2 obesity picture. So say the patient has dyslipidemia or PCOS, or elevated liver enzymes that make you think MASLD's the name for it now, right? But, fatty liver disease, that gives you a hint that kind of insulin resistance type metabolic picture is going on too.
To that point, so it sounds like, a lot of these kind of metabolic related syndromes can go hand in hand. So,
Sure.
NAFLD and
Yeah.
Are there other, who should we be screening for diabetes? And are there other things we should be screening along with those as far as things like dyslipidemia or obstructive sleep apnea or NAFLD?
Right.
How do you kind of approach a patient that might be where you're starting to think about screening for diabetes and what to be screening for?
Yeah. So a lot of the guidelines start around age 10 for screening. The reason for that is seeing type 2 diabetes before puberty is pretty rare. We do see it, but it's pretty uncommon. That said, I'm a big believer that we want to, catch this before it ever hits. And so we tend to screen kids even younger than that with obesity, especially if you have a first degree family member who has diabetes. So a parent, sometimes if they'll say a grandparent has diabetes. And my next question is always, when's the last time you've been to a doctor? Because I feel like there's a kind of an age in there where they may not have been seen for 10 years, or sometimes a mom will be like, well, I just, gestational diabetes and I never followed up. Right. But we do just kind of fasting labs with the fasting glucose and A1C, hemoglobin A1C, I think is sort of our typical screen. And so again, if you're an at-risk minority, family history that's pretty strong, we definitely are going to want to hit those groups. But to be honest, we just sort of do it as protocol in those kids and get a good set of fasting labs on most of them in that weight category.
So you mentioned a couple times at-risk minorities. Can you talk a little bit more about like social determinants of health and some of these other things that we have to worry about in our patient populations?
There are socioeconomic factors that play into this too. Access to healthy foods, especially, fresh fruits and vegetables that may cost more, food deserts, that kind of thing. And then, I would just say life stress, right? It's real easy to be, what do I want to say? It's real easy to be on top of health when there's nothing else competing for your time and attention. And some of these families just have a lot going on, and they're just trying to get through the day. So I always make my goal to really understand the family and what's going on. Families don't do well when you hand down advice when it comes to lifestyle modification. I always tell the residents, no, I've never seen a family who's like, man, I was really struggling. And then I got this set of 5 pages from my doctor about healthy eating. And like, I totally turned it around. Like you have to get in there, understand what that family's life is like. Because lifestyle changes are the cornerstone of prevention and treatment both. So it's super important to do that. And I run a clinic for kids under 6, and you may think this is not related, but it really is, because I believe that you have to recognize these risks early. And there's pretty good data out there that weight tracks even from, pretty young ages. And getting kind of on top of what you can do with lifestyle younger when the kids have food preference. They're pretty open. They don't lock into food preferences, and you can create kind of that family environment that's healthy. They'll be more likely to carry that moving forward and reduce that risk. So I think one of the things we do is we wait too long. We wait until these kids are 10, 11, 12. Then the parents aren't watching them all the time. They're in school. They're around these their friends and other food sources. It just becomes a lot harder.
No, I do. I love that you kind of brought up some of those, like the social determinants of health and like, things like the stress and all of these, systemic and structural, frankly, oppressive forces that make it really challenging to pursue some of these like lifestyle behavior modifications that we're encouraging, but also just kind of understanding what, the physiological response of things like outward racism can affect a lot of these kind of health disparities. And so it's something that we do try to focus on in each episode.
Well, and I've had like very well-meaning trainees say things that are right or like medically correct. But like, for instance, like a parent will say, well, he gets free lunch at school or eats lunch at school. And people will say, well, why don't you pack their lunch? Like that would be healthier. And I'm like, okay, maybe that's not a viable option. Like either they don't have time to do it. They don't have resources to pack a lunch like that. So like I always say, what can you move with the family? Get to know the family. What, it's shared decision making. And I think we're kind of late to come around to that. But the newest AAP guidelines really talk a lot about a longitudinal relationship with your provider in terms of weight management and shared decision making and the importance of that. And that's true whether you're just treating obesity, which is another love of mine. So forgive me but they're related, right? Or type 2 diabetes or dyslipidemia or whatever you're trying to treat that has a lifestyle component.
Is there a relation between like, say, food insecurities and diabetes?
So I don't know that link has been studied specifically, because again, I think diabetes has a lot of genetic, type 2 is actually more genetic than type 1 diabetes is. But I do think that there have been links between food insecurity and obesity for sure. And sometimes that's a little hard to wrap your head around. But I think there's behavioral reasons that tie that in. And then also the food that is available and when is not always the highest, quality of food.
One of the things you mentioned that I also want to go back to before moving on is puberty and the idea that there's not a lot of type 2 diabetes pre-puberty. Is there a role that puberty plays in the development of type 2 diabetes? That sounds like a complicated endocrinology thing that maybe someone tried to explain to me once and I never quite got.
Yeah, I mean, there's a natural insulin resistance that you get during puberty, even healthy children who don't go on to develop diabetes. So that's probably part of it, is that worsening insulin resistance. You also like fat distribution and where you put fat is different after hitting puberty, and that probably plays a role metabolically too into that. I mean, there are other things that we don't see until later, but some we do, like mast cell we'll see young. Like we can see that in 2, 3, 4-year-olds even. So there's still some parts we don't fully understand to that. But we have had, I personally have taken care of 2 kids who were not pubertal when they developed diabetes, and it was very classic type 2. So you still got to think about it. And I think that's just, again, the importance of screening.
Something else that you had mentioned that I wanted to kind of circle back to was the role of other medical conditions that may impact a patient's likelihood of developing type 2 diabetes. So things like PCOS or other conditions that, may necessitate a certain medication that increases insulin resistance or hyperglycemia, in the blood, things like psych meds or steroids. I'm wondering if you can talk a little bit about the role that other conditions can play in the development of type 2 diabetes.
Yeah, sure. So some of it is, I think, shared genetic risk, like PCOS and type 2 diabetes. I don't know that one necessarily makes the other one more likely, but they both have kind of shared genetic risk and insulin resistance as part of the pathophysiology of those conditions. Certainly the meds, though, we see a lot of steroid-induced diabetes. Now, we tend to label that differently. Like we don't, there's an insulin resistant component, but we'll call that like medication induced or steroid induced diabetes. But we're seeing a huge upswing in the use of second generation atypical antipsychotics. And those drugs absolutely do increase your risk for both weight gain and type 2 diabetes, especially at risk families. So that is another group that we would absolutely screen, I think, sooner than puberty, just to get an idea of what those sugars are doing and making sure that they're metabolically healthy on those meds. But they're good meds, So I always tell the families, we're not going to take this med off if this is the medication that gets your child through a normal school day. Like, we're just going to work around this, But then it's more aggressive lifestyle modification and then other medications that we'll use, like metformin.
So question about the steroid-induced diabetes, you sort of categorize this a little differently. I'm wondering, the incidence of actually being diagnosed with type 2 diabetes after a known previous episode of steroid-induced diabetes, sort of when I think about pregnancy-associated diabetes, right. A lot of times those patients are considered higher risk for diabetes later in life. Do we see the same sort of thing if we've seen this with steroids?
Yeah, I think we do. I actually don't know that data. But I do think that when we're taking the family history in those kids, so say we have someone who's on steroids for another autoimmune condition or, cancer protocol or whatever, a lot of the ones who do develop this do have a family history of type 2 diabetes. And I think that probably is a risk down the line, but not always. And sometimes you stop the steroids and the whole thing resolves, even though they have significant hyperglycemia. So that's another category you kind of don't know until you hopefully can wean them off the steroids and kind of see where you land.
And then, so maybe to that point too, I think there are times, and especially in the inpatient where I work with residents, where you might see an elevated glucose. You might see hyperglycemia because of the child with asthma is getting steroids or something. And we kind of talked about that. That does not mean that they have type 2 diabetes, although I love this idea that perhaps that there's a risk or that, it's kind of unmasking a predisposition. But can you talk about what is the criteria to say we have a diagnosis of type 2 diabetes in this patient?
Yeah, I know. Great question. So part of the criteria is you can't be on a medication that causes hyperglycemia. So that's part of the American Diabetes Association criteria. So the criteria for diabetes diagnosis is what you kind of get to first, and then it's what type, are you looking at, right? So a hemoglobin A1C greater than 6.5, a fasting sugar over 126, which is a weird number, but if you use the units the rest of the world uses, a less weird number. And then if you want to do an oral glucose tolerance test, we don't see those a lot in kids, but it's a good test. It's a great test, actually. It's just a little harder than a fasting draw. But the criteria for that is at the 2-hour mark if you're over 200. And then there's the one that's a little trickier is people use a random over 200, a random blood sugar over 200 is probably suggestive. But again, that one gets a little tricky if you're sick or stressed or something. Sometimes you'll see that, but all the other markers are normal. But that's another criteria that we use. So the first step is just diagnosing diabetes, and sometimes that's very obvious. So in Rachel's case, that's an A1C of 6.7s over the 6.5 cutoff. So that's your diagnosis. But then is it type 1 and type 2 or type 2 diabetes? Or now we know things about monogenic conditions, and that's a whole other topic we could talk about. But that is sometimes really challenging in kids to figure out, because type 1 diabetes and autoimmune conditions can happen in children with obesity too. Right? So like, it's not like if you have a child with BMI at the 95th percentile, they don't have type 1 diabetes. So we always send islet cell antibodies because we want to look for that autoimmunity. And in a type 2, in theory, those should be negative. And when we do like research studies, to qualify for the studies, you have to have negative autoantibodies. That said, a significant portion of people with clinical type 2 diabetes will be GAD positive, which is one of the antibodies. And we don't kind of know what that means. And if they're more likely to need insulin, if that could mean that they would tip to a more aggressive, form later. So it can be really complicated. And I don't know if you guys know this, but this is like legit fact. I'm not making this up. There is a code for what's called type 1.5 diabetes.
Yeah.
And that is for these kids. So it's like type 1.5 managed as type 2 or 1 point, because it's kids who have maybe one islet cell antibody positive, and it's usually just one, but it can be more than one, but then have signs of insulin resistance. So you can measure like C-peptide and insulin levels, and those aren't low, they're actually high, indicating insulin resistance. But a lot of times those kids have ketones or they present in DKA. So the picture's not always as clean as textbooks, I think, like make it out to be. And sometimes that's challenging.
As a resident versus general future pediatrician, med-peds practitioner, what would be the indications for me to send those antibodies versus referring to an endocrinologist?
Yeah, I would. If you have a good panel for it at your institution and you know what those are, that would help us out a lot, even if they're not sick enough to come into the hospital. So say, a 6.7 can wait for a clinic visit, but having those antibodies in hand when we see them allows us to do really nice counseling on what type and what we think the future treatments could be. Because it gets real sad if you tell a kid, hey, you know what, if we just get on top of lifestyle, this could reverse. And then we send the antibodies and there's 2 or 3 positive islet cell antibodies. Oh, we hate to be in that position, right? So I think, we tend to hedge our bets a little bit until we have those islet cell antibodies back. Or again, like sometimes that fasting insulin and C-peptide level are really helpful to determine if they're more insulin resistant or deficient.
And are there certain antibodies that are the go-to, or like what panel? Because I also remember like zinc transporter 8. I remember learning as a pearl was like a really good one.
That is pretty impressive that you spit that out. That was actually the last one added to the yes to the panel. So it's GAD, insulin auto antibody, I2, and the zinc transporter. So I'm really impressed. We have a panel, and I think a lot of institutions do. I do see occasionally people in the community will send like one, and I'm like, I didn't even know that existed. It's like a single antibody, test. But those are the 4 that we typically do send, and there are now ways to get that screening done, like even in the community, like JDRF, the Juvenile Diabetes Research Foundation, offers that screening for families for a pretty reasonable price on their website. So if you have that history and you want to know if your child's at risk, there are other ways to get it besides typical, insurance paid for blood draws.
So I want to wind back a little bit. So you were talking about getting hemoglobin A1C, getting fasting glucose, or maybe even a random glucose or glucose tolerance test. My question is like, do we have to have, if I just get this one A1C, does this mean diagnosis, or do I need more than one to tell me? What do we do if they're incongruent? Like I grabbed morning labs and their morning glucose was 120, but their A1C ended up 6.7 or something like that. Like, what do I do with that, and how do I navigate?
That is a great question. The ADA actually says on their criteria that it needs to be at 2 different time points or like 2 different clear-cut measures, right? So like in your case, I might just repeat that, in a month and try lifestyle or metformin or something. Part of it is I hate to give a child a diagnosis of diabetes if it was this one measure, because it does mean things moving forward. Now, some things are perceived as positive things. For instance, now you qualify for GLP-1 receptor agonist, which is also used for weight loss. So sometimes people say, you know what, let's go ahead and start that medication and just call it. But like things even like getting health insurance as an adult, like if you carry that diagnosis, can have an impact, right? So I like to be pretty clear cut and feel good about it. And sometimes you do, Chris, exactly get those sort of mixed ones or borderline results.
So maybe when you do your repeat, then you can also add, that's when you would also add maybe your antibodies at the same, your autoantibodies at the same time. So you just like complete your workup just to see where we're at.
Absolutely. And the other thing too is kids say they're fasting and they're not fasting. Oh, were you fasting? Yeah. Okay, because their mom told them to fast, but they were up playing like Mario Kart at 2 a.m. with
drinking Fanta.
Yeah, and sometimes you get a hint, like, actually it's not recommended to send insulin anymore. That's no longer on the guidelines for reasons, but like the fasting insulin will come back like, 150 or something. It's like highly unlikely, so you can get a hint. So I definitely, especially if I see that quote fasting glucose high, but the A1C is pretty normal, I definitely don't want to call it based on that. I'll repeat measures.
What about pre-diabetes? Is there a pre-diabetes range, and do we care about that, or do we just say, hey, they're not quite diabetic yet?
Yeah. I super care about that. We actually started pre-diabetes clinic within our division because I'm very passionate about like, don't wait for it to happen, right? Like we want to catch it earlier. Now in kids, and I'll tell you the criteria in a minute, in kids, it's tricky because that sort of path from normal glycemia to pre-diabetes to diabetes that you see in adulthood isn't actually true in kids quite as cleanly. And it's probably due to this insulin resistance during puberty, right? Because if you look at prediabetes in kids, which is an A1C of 5.7 to 6.4, right? 6.5 and above is diabetes, or a fasting of 100 to 125, where 126 is diabetes. That is pre-diabetes. Or you can use an oral glucose tolerance test again, with that 2-hour value being 140 to 200. So those are all textbook, like boards questions for those criteria. But I really do think, even though sometimes pre-diabetes has been shown to resolve in kids, especially again, if you have that family history or other risk factors, it's really important to start those conversations, I think, about prevention and making sure lifestyle modifications happening to the best of the ability of the family.
One last question before we move on.
Yeah.
Every once in a while, I look in the chart and I see a patient and they get a diagnosis of insulin resistance. Mm-hmm. What does that mean? Is that the same thing as pre-diabetes, or they're diabetic, or does it mean nothing?
Well, so I think, okay, the honest truth, like I tend to use that one too, because insurances will pay for that. Like
that's how we get them into endocrinology clinic.
Yeah, pragmatically. Well, don't send everybody with insulin. We would be seeing a lot of kids. But again, like a lot of kids have insulin resistance. They have no problem whatsoever with their blood sugar. Ever, so those two things, although insulin resistance is part of the pathology, you really need like some beta cell hit, genetically to really develop that. So insulin resistance, I've seen people bill that just seeing acanthosis, which is probably fair, right? You can also just bill acanthosis. But I do think prediabetes is an important code. And that means something to me when I see that. It means, okay, like you've actually hit that middle ground spectrum of blood sugars, where insulin resistance, your fasting blood sugar could be 70, but your fasting insulin, if you did choose to send, it's like 40, right? Those kids could still be at risk down the line too. That doesn't mean they're never going to get diabetes, but the pre-diabetes kiddos, those are the ones that I worry about and want to be more aggressive in.
And it sounds like the insulin resistance might just have high insulin levels, but that they're like compensating almost. Like they have insulin resistance, but they also have a lot of insulin production. And so they're able to maintain glucose homeostasis. That's cool.
So we should send for insulin levels then.
No, so you're not supposed to. So I'll tell you. So that
because we don't care about insulin resistance.
No, I know, but people do. That has been a wreck that has been hard to die, even in the endocrine world, I think, because we've just done it for so long. The arguments are that, again, insulin levels don't necessarily predict disease. Right? Like you can have an high insulin level and never develop. The other argument in kids is, of course, you can have this natural insulin resistance during puberty, even healthy kids. So you could get a high level that's still technically okay. And then the other one's just like a lab thing, but like the assays have a lot of variability. And so if you run a kid's insulin on multiple platforms, like you'll get different things. And so for all those reasons, it was recommended by Endocrine Society and I think AAP too. to stop doing insulin as part of screening labs. But I can tell you in our institution, that is an old habit die hard. Like I see them all the time. And to be honest, sometimes I'll get them in kids with extreme obesity because it can be a hint of certain genetic things that we now know predispose you if that's really high.
Still talking about a little bit of diagnosis in A1C. I'd love to talk about some of the nuances of patients with hemoglobinopathies. So whether it's sickle cell disease or perhaps sickle cell trait or even some of the more minor hemoglobinopathies, like if they have hemoglobin, C or E or some of these.
Right.
Or
most labs will tell you, like they'll run that and be able to say like there's interference in the assay because of a hemoglobinopathy. In the kids that have one, there are other things you can do to get an idea of glycemic load, because hemoglobin A1C, if you guys remember, is based on red blood cell turnover, right? It's how much sugar is like literally stuck to those red blood cells as they sort of float around. I kind of like literally picture it that way, like sugar cookie dough balls that like roll in the sugar,
Totally.
like how much is like stuck, in time. And when we assume like a 90-day turnover, that's why we ask to see those diabetes patients every 3 months. It's kind of like a whole new start, but that's not true of everybody. And there's actually some good evidence that even across normal populations without hemoglobinopathy, some people may be 70 days and some, maybe longer. So hemoglobin A1C isn't a perfect test for a lot of reasons. OGTT is the cleanest, to be honest. I don't think we use it enough, to be honest. So if I had a kid like that and I was concerned, you got a couple of options. You can do a fructosamine, which is not based on red blood cells, but based on albumin and glucose and protein. But I find that I use it. I find it a little hard to interpret, maybe just because I'm not as used to that range in my head for like what it means. But there are charts that will convert those two. Like if you have a fructosamine, this is about an A1C of this. Now it's pretty easy to get glucose sensors, and you could just do real day, like 14-day of CGM and take a look at it and get a pretty good view, or an oral glucose tolerance test. And those aren't super expensive to do. Sometimes the way we do them, they are, because like we bring them and put the IV in and stuff. But like if you do it like adult docs do, this is one thing I think they just make you sit in the lab for 2 hours. They draw your blood, they hand you the Coca-Cola, have you drink it, sit out in the lab for 2 hours and bring you back. You don't get a cushy room and the IV and all and all that stuff we sometimes do. But that should be a really nice look at glycemic load, no matter what else you have going on in the background.
Can I ask you since why fructosamine is not a thing that people do? It just seems like this great short-term glycated protein that you can look up. But I feel like even pediatric endocrinologists aren't super excited about it. And if you're making a small change, it seems like a great thing. But is it not reliable? Do you have a sense that is this the A1C of the future? Why does everyone hate fructosamine?
Yeah, so it's a 2-week measure instead of 3 months, so you don't get quite of the same long-term picture of what the glucoses are doing. I honestly think part of it is because you just don't have that spectrum in your head. We don't send it enough. So like every time I have to look and use like the conversion chart, like, wait, what is this? And I think in today's world, just real-time data is easier to get. You can get blinded sensors that insurances will pay for just to get an idea. But then honestly, Libres with I'm not supposed to say, I don't think that's a generic, but Libres, you can go get in the pharmacy relatively cheaply, even out of pocket, to get a nice 14-day, look. And it goes to the cloud. The provider can just pull it up from your office. And that's something even primary care docs could in theory do, if you wanted to. Or send them home with old school, right? It doesn't have to be that. You can send them home with a monitor. And my favorite thing is like
dip your pinky in the pee, and then if it's
we're not going that old school, Justin. We're not going back to
that was Oregon Trail days. Yeah, Oregon Trail 1.
Oh my gosh. No, but like what I'll tell them is like kind of like an at-home glucose test, right? Especially if like grandma has a monitor, mom has a monitor or something, I'll say give the kid a big meal, like pizza meal or pancake meal or something with a lot of carbs, and 2 hours later poke the blood sugar and tell me what it is. And if it's up in 250, then that's a cheap, easy way to get really good data on somebody.
That's awesome. Okay, so unless you, Nancy, have any last minute thoughts about the diagnosis of diabetes, I would love to bring us back to the case so we can start talking a little bit more about treatment. All right, so you take all of this data, you discuss the diagnosis of diabetes with Diane and her mother. Her mom isn't surprised. She mentions that both herself and Diane's grandmother both have diabetes as well. She asks about the treatment for Diane. So I know that it's opening up a can of worms, but I'd love to discuss the mainstays of type 2 diabetes treatment in kids.
So lifestyle, again, absolutely the cornerstone of every case, no matter what your A1C is. But I think first line medical, and honestly to 6.7, you could offer just that. If you had a very motivated family who said, if I had that family come in and they say, man, I just do not want my child on medications. I'm really motivated. We're going to do this. I would have them meet with a dietitian for sure. We're lucky in our clinic. We even have an exercise physiologist, which I realize a lot of places aren't going to have that. But, we have those resources in those clinic. And I'd say, okay, and then let's meet with these guys, really come up with a plan. And I would feel safe in that case with monitoring, waiting 3 months to bring her back off meds. But once you're getting up over 7, I'll put a medication on. So metformin is first line therapy, adults and kids. It's a really safe medication unless you have someone with pretty significant kidney disease. Otherwise, it's safe. And you would know kidney disease, right? Like I don't go around screening, kidneys and everybody I started on. But of course, there's side effects to that medication. I think most of us know what they are because we've had patients who've had them, but they're not pleasant, right? It's like if they don't tolerate it, it's abdominal pain, diarrhea, gas, and some of it's like 20% of people just can't take it. My personal practice is to start extended release because kids don't want to take meds twice a day. And I use a 750 pills that gets you to 1,500. It's not the full dose, but it just keeps you 2 pills once a day versus 4 pills once a day or 2 pills twice a day. And in kids, I find you just get better compliance and it gets you most of what you need. And then, when I started this, it was insulin. That is literally all we had in metformin and insulin. And boy, times have changed. And it's a really exciting time, I think, to be in this field because I feel that people have recognized that we need to be aggressive in these kids. One thing we didn't talk about the disease is type 2 diabetes in kids, for whatever reason, is a much more aggressive disease in adults. So the rate of time to complication, the time to complications is much shorter in people who are diagnosed in their youth than older folks who get diabetes. And so these meds that were initially approved for adults, such as GLP-1 receptor agonists and SGLT2s are now approved in kids, which is huge. And those medications are also great because they're the GLP-1 receptor agonists are weight loss meds too, right? So it was so exciting to have medications that actually led to weight loss instead of weight gain and diabetes. We had literally never had that before. And of course, that's a whole can of worms too on how those are used, but they're good drugs for type 2 diabetes. And then SGLT2 inhibitors are renal protective. And these kids have high rates of developing renal disease. So those are nice medications to use too. So we're thoughtful about what we pick. There are indications where, like, say you had a patient that got pancreatitis. Frequently, we would not go to a GLP-1 receptor agonist. So there are things like that we look at. But we can basically do a lot of the medications you can use in adults with a few exceptions.
Are there age-related choices for those in terms of what's FDA approved? And are some GLP-1s, I mean, I don't honestly know, like which, I know there's so many GLP-1s out there, and then also the whole back order issue. And
oh, yeah, exactly. It is so hard to keep straight. Like I do it all the time. So I keep it straight, but it's pretty tough because semaglutide, which is Ozempic, right? That is approved 18 and up for diabetes, but the weight loss form of semaglutide is actually approved 12 and up for weight loss.
Oh, I didn't realize that.
Yeah, it's basically was easier to do those trials for weight loss than it was because there's just not as many type 2 kids. So they went for the weight indication first. Yeah, dulaglutide is approved down to 12, and liraglutide is approved down to, those are both approved down to 10, I believe. So we can use those two medications. So liraglutide's a daily, and the compliance is so much better with weeklies that I tend to go for that. But these days it is really frustrating to try to get these medications through insurance. So what happens is you'll put one in and the insurance will say, that's not my preferred product. And then you'll put that one in and they're like, that's approved 18 and up. And I'm like, okay, but like the one under 18, you told me I couldn't. So there is a lot of effort to try to get these drugs. And then Chris is absolutely right. Like there's a shortage of a lot of them, especially with people turning to them for weight loss. So sometimes I'll write a dose and it's not in the pharmacy and we have to make a lateral move to get them on medication to keep it. So it can be difficult, but by and large, we're able to get those medications for kids. So yeah, I misspoke. It's down to age 10 for type 2 diabetes in dulaglutide, or sorry, I'm so used to calling them by their brand names. Semaglutide, liraglutide. Now the dual incretin therapy, tirzepatide, that's pretty hot right now. Mm-hmm. That is 18 and up. So we have a hard time.
That's the one with the GIP, right?
Correct. Yeah. So that is superior to the GLP-1 receptor agonist alone in terms of both weight loss and A1C lowering. So that's a nice medication if you can get it, but it is expensive, and a lot of the insurances will make you fail a GLP-1 receptor agonist first before they'll approve the dual therapy. But some of them have them as preferred, so you just have to put it in and see what happens, honestly, a lot of the time. So you need to have people who have your back for like PAs and letters, because there is a lot of that in type 2 diabetes these days.
Yeah, it's really unfortunate. We have a wonderful pharmacist who helps with a lot of those things. I'm very grateful for that team. I wonder if I could ask, I feel like with adult diabetes, I have this like almost chalk talk of how I approach someone with type 2 diabetes. We're worried about macrovascular complications because that's often what's going to get them, like a heart attack or a stroke. And then the microvascular complications of retinopathy and nephropathy and neuropathy. And I talk about how we want to prevent heart attacks. And so we look at all the other risk factors. And those are more some of the specific medicines that have shown to improve reduction, so SGLT2 inhibitors and GLP-1s. But for someone with like neuropathy or nephropathy, it's really about A1C reduction, which might be a little bit of a different strategy, and things like insulin. It sounds like for kids, because the complication rate is a little quicker, or the time to complication, I'm not sure if that's actually the right approach, and that the macrovascular complications, I don't know that there's benefit for in kids, and are, I presume, less likely to be an issue before neuropathy and nephropathy. Do you kind of think of these? Yeah. How do you think about it?
So the Today study was this huge type 2 study in kids, and a landmark study. And what it was trying to do was look at different treatment plans. And what happened was, while they were doing this study, these new drugs got approved, and now we don't, like TZDs was one of the treatment arms, like we don't use those drugs now. So, but it was really important because they followed this kid cohort out, and they saw strokes and other macrovascular things in 20s in these kids. And that was why we say, it's mainly that study is why we say that type 2 is more aggressive. So we do very careful blood pressure readings, and there are guidelines about that, but making sure that the blood pressure is well controlled. We talk to the kids about vaping and smoking, which really anybody should do, but like we make a huge fuss about that because we don't want any additional cardiovascular risk. So blood pressure, we pay close attention to. Again, vaping and smoking, we do lipids very routinely, and we all know as diabetes doctors how to treat those. And then protein in the urine test, you do that right at diagnosis for type 2 diabetes, even in kids. And we even have a eye camera in clinic now to make sure, because again, we want to be very aggressive in screening, and our ophthalmologist then read those studies. But yeah, we want to be really aggressive, even in kids, at understanding what those other risk factors for vascular disease are.
Do you do diabetic foot exams
I have to admit, we do not do those as routinely as we should. We do them on occasion if they're complaining of symptoms. I do think that's one area we're behind in kids, because that Today trial actually showed neuropathy in some of those patients. And I think honestly for pediatrics, it's just we weren't well trained on how to do those. That's a very adult thing that we don't do a lot of, in kids, and we don't do those in our patients with type 1 diabetes either in our center. So I have to admit, I think that's something we probably should be catching up on in the next couple of years. Huh. I don't even have anymore the little filament. I could get one, I'm sure, but
you can break a popsicle stick or the tongue depressors.
There you go.
That's our cheap pearl.
Yeah.
At Cashlack Hospital.
Yeah. But we really are, at least in our division and in our group, we are really aggressive at trying to get to target. We're constantly having a conversation the A1C is not below 7. What are we going to do next? Because even if you just think of how long these kids are going to have diabetes, right? It's not somebody getting diagnosed at, not that it's not important, but it's not somebody getting diagnosed at 70, right? Who doesn't have 30 years of diabetes, maybe any, these kids could have, 20 years of diabetes and they're 35, so we're very aggressive in terms of management. We use a lot of, again, CGMs and glucose monitoring tools in kids, and those are approved.
So what are our goals that you're shooting for? Are they different if you're using CGM versus a regular glucose monitor finger stick? And for A1C, if it's so important, why don't we shoot for less than 6.5 or 5.7 or even lower than that?
Right. I think the lower, the better for sure. I do think it's always a balance of how much burden you're adding. How much medical burden versus what's your risk? We know under 7, you're in a pretty good spot from different forms. One of the forms of monogenic diabetes, there's no treatment for, and those people run low 7s and under. And we know from following them long term, they don't have complications. So it's kind of a nice group to look at. They don't always have the same vascular risk, I suppose, too. But in any case, yes, under 6.5 is great, but I tend to use 7 in kids because some families, the more medications you add, the more likely they throw up their hands and don't do it. And I don't know if you guys have seen that in your own practice, but it's always a little bit of a sweet spot, how are they doing the ones you have them on now? If they're not taking their metformin and they're missing half of their GLP-1 and their A1C's high, throwing another medicine on is not the answer, right? You're spending time. Why are you missing this medicine? Are you concerned about it? Are you concerned about the cost? Using your pharmacist friends if you have them. So again, it's really getting to know the family and what's going on. And sometimes we are using insulin. Sometimes we're using full basal bolus, and those tend to be the kids who make ketones and a lot of the ones that get in DKA and sometimes we're using insulin pumps, right? So it's, again, kind of exciting time to do this because we have so many different treatment options. But we really want to do what's going to get the child the best control. But also, again, I always think of it as really building lifestyle stuff so that you can try to start peeling some of those meds and not even, needing them in the first place.
So maybe on that too, and I think this is probably going to be the same answer, but I'm still curious. I feel like for adults that have pre-diabetes, we hem and haw about starting metformin because there's some evidence on this DPP trial that it decreases conversion to full diabetes. And I would think for kids, we would also want to be super aggressive. Is this something that you have discussions with families about? Do you start metformin in pre-diabetes for kiddos?
No, that is an awesome question. I think we debate that a lot. I think we used to do it more actually than we do now. I think in the beginning we just were starting it, left and right. And a lot of those kids really weren't progressing on to diabetes. And then it's when do you peel it off, right? Or if the child has done really well, how do you know when to stop it? So the times that I use it, I think, are the kids who are really close to the line. So the A1C is 6.3% or 6.4, percent, and maybe they already have fatty liver or they have an at-risk medication or something. Those guys, I absolutely will. Or if there's a really strong family history, or if I'm getting no buy-in at all in lifestyle changes. Sometimes they're this is what we can do. We really don't want to change this, or this is the food he likes. He's a very picky eater. I'm quicker to start medications in those families. And it's a little bit of a judgment. We're still going to work on them. We're still going to ask every time and encourage. But I worry that medications are where we have to go next. So we don't really, I think most of us in our practice don't have like a standard way we do it all the time.
Kind of on the other end of that, like in adults, we talked a lot about oral agents. And in adults, for example, like if we have an A1C greater than 10, we start thinking more about insulin versus an oral agent. I'm wondering if there is, a certain way that you think about starting insulin in kids.
Yeah, great question. So we do have those hemoglobin A1C cutoffs too. So anybody over 9.5, we're thinking insulin, at least basal insulin, if not bolus insulin. The other category we do that is if you show up with ketones or in DKA, you automatically buy yourself insulin, at least for a while. We do fixed meal boluses in kids. It took us a long time to get to that because we do more type 1 where we're very exact on the carb ratio. And that was a change that we did lately. It actually works really well for families to say, you know what, take 10 units with meals or 15 units with meals because they're insulin resistant enough. You really don't have to worry about that fine tuning that we do more in type 1 diabetes. But we do use A1C cutoffs to decide what we do and how many things we're going to add. And even the degree of education that we do in monitoring is based on A1C. So 9.5 is sort of so under 7 for some people use 6.5. You could do just lifestyle alone and probably metformin. That 7 to like that 9.5 is where we're doing at least metformin and probably another med. Metformin plus basal, metformin plus GLP-1 receptor agonist. And then over 9.5, 10 is where we're really thinking maybe we need to do basal bolus for a while until we calm things down.
That's super helpful. Thank you.
Yeah, I'll ask a med-peds question. I feel like one of the questions is going to be when to actually refer to pediatric endocrinology. I feel like these are medications that an adult primary care doc often does prescribe. But I remember in residency vividly talking to this pediatric endocrinology expert at Hopkins, Dr. David Cook, whom I love and was like this big name there who was like the expert. And I was telling him about how a lot of in the adult world, we just take these patients, even that have complicated A1Cs and don't refer to adult endocrinology. And I remember he was just like amazed, like really, like you'll take care, like you won't refer. And I'll be like, yeah. And he said, but what about ones that have really, high A1Cs? And I was like, no, we'll take care of them in primary care at CLU. Like I have tons of patients who have uncontrolled diabetes and like showing off and like puffing out my chest. And he was, very much like, they need to see an endocrinologist. Like, what are you doing? And I think it's like a cultural thing. But like, when should the pediatrician be thinking about pulling the trigger to send to pediatric endocrinology?
It is really rare for not med peds, just the peds part. Really rare for them to feel comfortable managing diabetes. It is hard to stay on top of all the tech and all the meds, and just even that experience of doing it. Even the structure of the clinic, like diabetes takes a long time. By the time you download their meter, you get your meter data or your CGM data, you poke for the A1C if you have that in your office or get that data. And then just your normal office metrics, plus then going through everything you need to go through. That is a solid 30-minute visit, if not longer. And a lot of primary care setups, they just don't have that, and so there's just a lot that you need to know. I think in the adult world, there's so much more type 2 that a lot of people feel more comfortable with doing that. The one thing I would say is type 2, again, is more aggressive in kids and you're more likely to need insulin. And it really is treating the family and making sure that that the whole family is being involved. So it's a little different model than maybe the adult model where it's just, you're having social work talk to the school and it might be a little different. But I think the other advantage is just we just have huge teams at these tertiary medical centers. So we have a huge pool of CDs, huge pool of social workers, dietitians, all those resources are right right there. So I think if you have, a teenager or child and their A1Cs such that you could just use lifestyle and metformin and that child's doing well on that, or even maybe a GLP-1 receptor agonist and that child's staying in goal and you feel comfortable doing that, great. I just don't think there are a lot of people who do in pediatrics.
So we're getting really, really close to the end.
Okay.
And we always sort of want to I always want to ask a really hopeful question as we get to the end, because some people, after hearing all this can be difficult and complicated. And so I think what's cool about diabetes management in the most recent years is so much has happened. Like we have all sorts of new treatments like targeted GLP-1s, SGLT2s. We have new types of monitoring, like CGMs are now so widely available. Are there any new treatments or management things that you are seeing on the options outside of what we've just talked about? Is there any cool things that you're like really, really excited to come down the line?
Honestly, not that I've heard of for type 2. There is actually believe it or not, a tri-agonist therapy in development right now that is GLP-1, GIP, and glucagon receptor agonist. And that preliminary data is insane in terms of how much weight these people lose, and especially in how much fat in the liver. Having the 3 does really neat things for that. So I think it's going to be good for our patients long-term to keep having these options. I think the drive is sometimes money making behind obesity, right? Because of sheer numbers and how many people want, but it's good for people who have real, true disease and metabolic disease. It's going to help them. I think a lot of the exciting things actually in type 1 diabetes.
Artificial pancreas?
Yeah, there's so much. We have prevention medicine now, an FDA approved prevention medicine. That is huge, and exciting. But I think type 2 is always going to be challenging. The rates are going up, and there's good data that shows that through the SEARCH study. And our environment is not changing for the better, right? You can literally never leave your house. You could have Amazon Prime and Kroger Click List and never leave your house. And kids are more and more on screens. Kids are more and more on screens. That's not getting better. That's not going away.
Kids playing Oregon Trail.
Bring it back.
I would love it if a child told me they were playing Oregon. Yeah. So it is challenging. I don't want to sound not hopeful because I think the treatments are so good. The treatments are really nice now. But the underlying, disease rates and how we got there in youth, which we didn't really even see 30, 40 years, too often 30, 40 years ago. It's kind of hard to be a little hopeful, about that. But I guess there are groups in the United States, many very good groups who are passionate about treating these kids and families. And these kids can get really good care. And I'm sure they can in primary care offices too, to some extent. I just don't see it as much in the peds world with that. But yeah, good question though, Chris. I want to end hopeful too. I do.
I love it. I think that's a great question to end on, and I think this has been an incredible conversation. I feel like we've gotten through diagnosis, treatment, lots of great stuff for type 2 diabetes. So, Nancy, thank you so much for your time, for your expertise, and for coming on the show.
Yeah, my pleasure. Thanks for having me today and getting to meet you guys. It's really nice. It's great what you do.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids!
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Rachel Holloway, our showrunner, Dr. Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Rachel Holloway.
And this has been Chris the Chew Man Chew. Thank you and good night. And for those who made it all the way to the end, you're not going to forget that I'm going to give you a poem written by AI. In a world where youth should run and play, as shadow looms in the light of day, type 2, once rare in children's tales, now finds a path as wellness fails. Sugar's sweet lure, a constant call, in blood it rises, in youth it sprawls. A silent march through vessels wide, where insulin can no longer bide. Pediatricians with eyes keen spot signs where health once had been. A test of blood, a prick so slight, reveals the numbers, brings the plight to light. Lifestyles change, a course set new, with diet adjusted and exercise too. Medicines join a supportive cast to slow the march to make health last. In clinics bustling and rooms that heal, a commitment made with fervent zeal to turn the tide, to lift the haze, and gift these young ones brighter days. See you guys.